Okay, I'm going to convene us. Good afternoon, good morning, or good evening, everybody. My name is Sandro, Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Before we begin, a word of thanks to our collaborators on today's event, the Rockefeller Foundation Boston University 3D Commission. Thank you also to Meredith Brown and Alicia Noel, who made today happen. This is part of a series of events we are hosting on the coronavirus. This pandemic has been unfolding rapidly, giving little time to reflect. These events are meant to provide such time, helping contextualize COVID-19 through the lens of contemporary public health issues. This is the 10th of these events that we have hosted, with topics so far that have ranged from the economic consequences of COVID-19, the science behind the virus, its mental health consequences, and the intersection of the current pandemic with climate change. After today's seminar, we'll take a hiatus from the series, respecting the academic calendar as we enter the summer months. We thought then it would be fitting in this last event for the time being to broaden our lens. As we navigate COVID-19 in the US, it is sometimes possible to develop tunnel vision about the crisis and see it primarily from a North American perspective. This is understandable as we are rightly preoccupied with mitigating the pandemic's effect on our local communities. But it seems to me that this makes it all the more important to take a global view. Seeing COVID-19 through a global lens, learning from the experience of other countries, can help us mitigate the pandemic in the near term and lay the groundwork for a healthier future. We are honored to have an outstanding panel with us today to help apply a global perspective to COVID-19. Each panelist will speak for about 10 minutes, and then I shall moderate questions from the audience. Please feel free to use the question tab in your Zoom browser, and I will do my best to get to as many questions as we can. Our first speaker is Dr. Kalpana Balakrishnan, Director of the World Health Organization Collaborating Center for Occupational Environmental Health and Professor at the SRU-ICMR Center for Advanced Research on Air Quality, Climate and Health at the Sri Ramachandra Institute for Higher Education and Research in Chennai. Dr. Balakrishnan.
Thank you, Dean Galea. It's a great pleasure. I'm delighted and honored to be given this opportunity to share my perspectives from India on COVID-19. You will all agree that what we are collectively experiencing today is like nothing else we would have thought possible. And while each one of us is reeling under the impacts of COVID-19 in one way or another, it is not often that we get to hear other country perspectives. So thank you for that, Divya, upfront and close. So when you asked me to speak at this seminar, I was so eager that I too did something that I have never done before. Give a talk between 1:30 a.m. and 2:30 a.m. From India. So pardon me if my reflexes are a little slow, but I will try my best over the next 10 minutes to give a feel upfront and close for our experiences here in India. Well before the number of cases began to rise in India, Prime Minister Narendra Modi instituted a national lockdown on March 24, requiring nearly 1.3 billion people to stay home. This at a time in India when we had just under 500 cases and 10 deaths. Within a few days of the lockdown, our skies were blue. As you can see, the India Gate that is normally not visible became visible from several feet away, and the neighborhoods became quieter. We had never experienced our environment and our community spaces this way in recent memory, and that was enough for the minds of the 1.3 billion people under lockdown to already go into work, thinking about planning and protecting their families, institutions, and the nation at large to brave this pandemic out. We are now in lockdown 4, meaning the 4th extension, and on day 65. We have tested some 3.3 million people and have about 158,000 cases to date and some 4,500 deaths. Nearly a third of this burden comes from the state of Maharashtra, the darkest red looking state that you can see on the west coast, with the city of Mumbai accounting for most of the state's burden. The state that has been most in the news for doing what only a few countries anywhere in the world have done, such as Vietnam or South Korea, is the southern state of Kerala, which with its population of over 35 million currently reports just 7 deaths and little over 1,000 cases. So clearly a major difference across states. For the purposes of illustration, I'm going to spend a few minutes each on the models of successes that we have had in the states and conclude with some personal reflections on lessons learned from the pandemic thus far. Our earliest model for success was from the textile city of Bhilwara in Rajasthan. It was one of the earliest hotspots with some 27 cases reported over just a few days. Bhilwara has a population of about 3 million. And within 3 days of the first positive case, by March 22nd, the health department had constituted some 850 teams and conducted house-to-house surveys at some 56,000 homes, covering some 280,000 people. Nearly 2,500 people who were appearing symptomatic were kept under home quarantine. In just over the next 4 days, under the able leadership of the civil servant Tina Dabi, nearly 6,500 people were home quarantined. 435,000 households and some 2.2 million, nearly all of the 3 million people who were in the city surveyed. Aggressive containment and extensive contact tracing were so successful that Bhilwara now has reported only 1 case since March 30th. This next model of success comes from Kerala. By January 30th, the day India and Kerala reported its first COVID-19 case, a 23-year-old medical student from Wuhan, as many as 800 persons with a travel history to China had already been kept under observation. Kerala has to date seen some 1,003 cases, 552 recoveries, 7 deaths, and has consistently stayed ahead of the curve with some of the highest recovery rates in the country. And there are several reasons for this success. First, in the context of flattening the curve for this pandemic, is the primary priority that Kerala has all along accorded to public health. With nearly 100% vaccination coverage, lowest maternal and infant mortality rates, best sex ratios in the country, highest levels of women's literacy, Kerala perhaps had some of the highest levels of preparedness to face this pandemic. Second was its ability to increase the expenditure on public goods. The WHO mantra of test, trace, isolate, and treat that Kerala was able to follow diligently was only possible on account of investments in public health systems, allowing Kerala to test at the rate of some 450 per million people, something that the markets could have never done. Third, the success in dealing with the crisis of this dimension lies in the social mobilization that Kerala was able to accomplish. From the Break the Chain campaign to setting up community kitchens to using umbrellas as a means of social distancing, the power of social mobilization was evident everywhere in Kerala. But perhaps the one thing that distinguished Kerala from every other country that had investments in public health but could not contain it to the same degree was that not only did the state have the ability to do something when something like the COVID would strike, but it actually did it when it was needed. Past experience was, of course, key, including the management of the Nipah virus, dengue, plague, and that helped invoke their innate resources very efficiently. Finally, may I also add my unbiased opinion about why really things worked in the states of Kerala and Bhilwara? They had some very efficient women at the helm of affairs and in charge of the action plans, I think. Health Minister, whom you can see on the right panel, Dr. Shailaja, is come to be known as the Corona Slayer in Kerala, and the young civil servant, Tina Dabi, whom image I showed in the last slide. As for the case of the states of Maharashtra, Gujarat, and Tamil Nadu, and a few other states, where the breaks are yet to come, the battle is being fought with great determination. The battle, no doubt, will be a long drawn one from local squads that you can see on the left-hand panel, who are conducting patrols in containment zones in the famous slums of Dharavi in Mumbai, to the general public, even in the most crowded neighborhoods, willing to respect the norms of social distancing, and to the health systems that have had their own creative ways to strengthen themselves during the lockdown period. It is going to require every iota of cooperation. Many, many lessons, sobering ones, reflective ones, have been learned. I can't certainly possibly, capture all the lessons that, many, many distinguished scholars and many, passionate citizens of India have shared over the social media. I will like to conclude my own, personal reflections about what I have learned I could do as a public health, professional. Being from South Asia and being a women professional in India, it is not uncommon for a lot of us to have a lot of empathy. We can really see this through the lens of others. But what we have, I think, often failed to do, it is not sufficient to have empathy, but we haven't been able to sort of give the skill sets, the empowerment that is needed for the likes of us, and to sort of really think that empathy and empowerment need to and actually coexist. Empowering, is a dimension that has not been paid sufficient attention to. And the equity in education, especially in public health education, it is still limited to the elite few who can actually travel to countries to acquire public health education where you have high-end public health education skills. Cannot be a better illustration of the COVID-19 pandemic about how the developed and the developing countries can come together to make sure that this equity, especially in public health education, is not a matter of choice. It is also, very common, especially for women in South Asia, that, we are a pretty happy bunch. We're pretty resilient. We are not sort of, overly upset about not perhaps succeeding so well in our homes or in our professions. We tend to take everything along in stride, but don't pay enough attention to our own health. We rarely find time to exercise. And what the COVID pandemic really, illustrated was when we had more time on our hands, we actually took better care of our health in terms of physical fitness. And that, health and happiness are really inseparable. When your body is not doing very well, it's really hard to stretch the happiness quotient very far. And finally, AI algorithms, big data, and no better than Dean Galea to know about data and determinants of health. We have many algorithms. Practical, pragmatic approaches that are applicable for some are necessarily not optimal. And so the pragmatic approaches tend to get buried under, the optimal lens and, don't see the light of the day. And I strongly feel, what is pragmatic and what is optimal should be guided by ethics and not by choices of AI algorithms. There are a lot of people for whom pragmatic choices make a difference between their life and death. They may not be optimal, but we have to necessarily make sure that these two go in balance. And finally, I would like to invoke the hashtag never forget. It would be so easy to forget everything that we have learned the second the lockdown gets lifted and the second we have actually a cure for the coronavirus or for COVID-19 or a vaccine to protect ourselves. I hope we never forget, and I hope this will be a lesson of a lifetime. Thank you again, and I look forward to answering some questions. This is just a teeny weeny perspective of a 1.36 billion nation. So with much humility that I present this, it is certainly not the perspective on India that you can perhaps receive. Thank you.
Dr. Balakrishnan, thank you. That was terrific. And thank you in particular for joining us at a very late hour for you. Really appreciate it. And I will remember always that decisions should be guided not by AI algorithms, but by ethics. Thank you. Next up is Professor Heidi Larson, Professor of Anthropology, Risk and Decision Science, and Director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine in the UK, and also Clinical Professor in the Department of Health Metrics Sciences at the University of Washington, Seattle. Professor Larson.
Is it, am I? Okay, great.
You're on, we can hear you. Thank you, Heidi.
Good. Yes, well, I'm here in the UK, and our news today is that we have the highest number of excess deaths per million people in the world. We are a small, not that small island, but the keep calm and carry on mantra that got us started too late, we're really paying for it. And Europe in general has been, as you know from just the news, if not the data, Europe has been hit very hard. It was the epicenter after China, and frankly, in the UK, we should have learned from what was going on in Italy, but somehow until it's tangible. I think one of the things that we're seeing even in Europe, never mind in the poorest countries, is decision-making is very much weighed against different risks, different costs. I think we're going through what I would call these emotional determinants of compliance in a way with some of the lockdown. We've had a long lockdown like many places. I think overall, the population here, even though it started late, has been remarkably compliant. There's been a lot of infrastructure put in to bring it into our daily life, structural changes, lines on the ground, a lot of messaging around that is a reminder. But what's been interesting, and this speaks to the importance of trust and leadership, and we see that trust in government, certainly in all of our vaccine confidence work across Europe. And my research group, the Vaccine Confidence Project, has been measuring vaccine confidence across Europe in collaboration with the EU in 2015, 2016, 2018, and we're just pulling in the data from 2020. It's highly, highly embedded in trust in government. We had one study comparing vaccine acceptance to political opinion polling. The more populist right wing you were, the more likely you were to be questioning vaccines, and we're seeing similar patterns in this last wave of surveys we've done, where we've said, if there were a COVID vaccine available now, would you take it? And interestingly, in the UK in mid-March, 7% said they would not take it. That dropped to 5% 2 weeks later when the mortality numbers started to go up. And now, as things are starting to stabilize, it's up to 9% saying that they would not take a vaccine. Germany, 9% said they would not take a COVID vaccine. Austria, it was 16% when there were more cases. It's up to 18% saying they would not take a COVID vaccine. 20% these are representative national samples, 20% in Switzerland said they would not take a COVID vaccine. France, it was as high as 26%, which is more similar to what some recent surveys in the US are showing. So this speaks to the fact that we can't assume, which I've heard from a number of people, oh, well, this big, awful pandemic is going to wake people up to the value of vaccines. Well, that's not necessarily the case. But I think where we have a compelling issue with COVID right now and the experience we're all going through is a different reason. It's so embedded in every other part of our life that it puts health in a contextual situation where I think people will take a vaccine, which is now particularly here where we have where the Oxford vaccine trial is going on, and it's in the news a lot. The most compelling thing I think is after this stabilizes is going to be, will this vaccine let me go back to work? I think the economics as the mortality is waning and we're at a different stage. It moved to the US after here, but what I see is that public compliance, public opinion is very emotionally volatile against the state of the epidemic, against the state of the economy, against school, against a lot of the other things that are being affected. Leadership is a huge lever. We see right now in the UK, as you might have seen in the news, Dominic Cummings, Boris Johnson's right arm, went 3-4 hours away in his car during lockdown to bring his children for childcare to his parents. The country is really angry. It was bad modeling. It was not the right thing to do. And they're not giving up on it. And it's taking a real toll on compliance. On the one hand, you think that there are states where people comply because they believe it, but the role of leaders and the power of leaders has been another thing we've seen across Europe in different places. I think that really the main thing at this point, we have a long way to go, and I think one of the issues is, and I was on another symposium this afternoon, and a question came back, when are we going to, because the other issue is that other services like routine immunization has been hit. When are we going to go back and get back to normal? I think this is, we know this is clearly not a go, no go to school, go, no go to work. We have to rethink how we do things in general. It's going to be how we do it. And in Europe, we're really in a stage of country by country looking at, okay, how are we going to do it? Are we going to open cafes? No, France is. We're not doing that yet. We're a little bit with schools, maybe every other week, staggering. I mean, there's a lot of different decisions being made right now. But I'll wrap up here, but I think one of the crucial things that is coming up across all of these areas related to COVID, but in general, is the power of trust or the lack of it. And I think with COVID, and we learned this a lot from H1N1, where people, you can use this time as an opportunity to make or break trust. There's historic memories, communities have memories of their experiences. This is going to be a powerful memory. We're going to have pre and post COVID in the world. We had pre and post 9/11. Now, I mean, we have COVID from a pandemic perspective. This is a huge game changer. But this is a huge opportunity for us to build trust. And that will be remembered. And we're in that stage where right now, the decisions we make in Europe, given where we are in this stage, people are really seeing that that's going to be an important aspect. Thanks.
Thank you, Professor Larson. Those vaccine numbers are remarkable. I wasn't aware of those. That's really remarkable. Thank you for your comments. Next up, we have Professor Sherine Shawky. Dr. Shawky is a senior research scientist at the Social Research Center at the American University in Cairo. Dr. Shawky.
Okay.
Good. Okay. Very good.
So as I said, I would just in brief present the COVID-19 situation in Egypt. When I started preparing these slides, I had a ready question in mind. What should Egypt do to reduce the burden of the COVID-19 threat? And that made me first look to the data and what the existing data tell us. Then what are the efforts in Egypt to hold the epidemic? And what are the key actions to consider? So to date, the first case in Egypt was detected on February 15th. And to date, we have 19,666 confirmed cases. From them, 5,205 recovered, 41 seriously critical, 910 total deaths, and the case fatality rate is 4.6%. There is an incessant increase in the number of detected cases, and the number is nearly doubling every 15 days. If we compare the total number of cases in Egypt to the Eastern Mediterranean region, we can see that Egypt ranks 7th after 6 other countries with much less cases than, for example, Iran or Pakistan or some of the Gulf countries. But what is more important about this chart, that it makes you see that the high-income countries have more confirmed cases than the other countries of the region. If we also look to the attack rate, this observation is more apparent, that the high-income countries are the ones who are more affected or the ones who have more confirmed cases than the other countries of the region. So does this mean that the high-income countries are affected more? Or does this alert us that the high-income countries have better screening and detection
Sherine,
actually, this Egypt dense epidemic reported. Yeah. Do you hear me?
You were breaking up. But maybe put your video off and just and try that, because I think you can keep sharing. It might be better for bandwidth.
Okay, like you can hear me better?
Yeah, like that. Keep going. Let's see if that works better.
Okay, so if we look to a rough estimate of the prevalence of the COVID-19 using a model that is based on death, we can see that on March 15th, Egypt has more than 50,000 confirmed cases, which means that the epidemic did not only start on February 15th. Certainly it was there before that date, but there was a delay in the detection of the cases. And also, to date, Egypt is suggested to have around 500,000 of COVID-19 infected cases. So if we also look to the deaths, we have an increase in the number of new deaths every 15 days. And the case fatality rate shows that April had the highest case fatality rate, but now it's a little bit improving. So does that mean that the country measures and the case management is succeeding in improving the case fatality rate, or are there cases that are underreported in Egypt? Actually, still Egypt is among the highest countries in the total number of deaths and in the case fatality rate. What did the government do? Actually, from the very first day, the government was alert to the COVID-19 threat and had made some measures, some public health measures for contact tracing approaches, testing only of suspicious cases and Egyptians returning from abroad, and and putting the critically positive cases in quarantine hospitals. The second thing, there were media campaigns everywhere where to ask people stay home, avoid going out, wash hands regularly, avoid physical contact, and self-isolate in case of suspicion of infections. Also, schools were suspended, labor force were reduced, public services were all suspended, all public events and religious events suspended, restaurants, cafes, and clubs were closed. There was a curfew from 7 p.m. to 6 a.m. in the morning. And then there was also extra curfews during the holidays. And we had two holidays, the Eastern holiday and the Eid holidays. But at no moment, Egypt had a complete lockdown. And currently the government is planning to reopen business. Actually, maybe the government was wise in this decision that they don't do mass screening or put all infected patients in hospitals to avoid overburdening the healthcare system that is already overburdened. The second thing, the government was maybe also wise in not doing a complete lockdown to avoid the negative impact of such measure on the economy of Egypt, which is already overstretched. Actually, if we come to answer the question that was posed at the beginning, I think with this very few information, it's very hard to answer this question. We have very limited data. We don't know, we don't understand the epidemic properly. We don't know who are affected, where is the epidemic growing, why are people dying or recovering, and many, many other lots of questions that we don't have answers for. So honestly, at this point in time, it's very hard to put recommendations for Egypt to follow in the future, especially that it appears that we will be living with the epidemic for some time, and maybe there will be also new waves of the epidemic. But there are three key priority actions that Egypt should consider. First, strengthen the production and sharing and use of data. Data are essential to make us understand the epidemic, understand the national response, understand if we're successful or not in the management of cases. There is a need for a paradigm shift in thinking. Data are not only for reporting, but data are for planning. We need sensitive indicators to measure the national progress to hold the epidemic. The second thing Egypt should consider to move resources to health and healthcare. The country has been suffering from underinvestment and under expenditure in health over the past decades. Maybe it's time to think on how to invest in health, because the health of the people is the wheel for the economic development. And we need adaptive, responsive, and resilient health systems to help us face any emerging epidemic. The third thing is that we need political commitment from the whole of the government. The COVID-19 epidemic is beyond the responsibility of health system. We need more integrated policies for social protection, securing food, ensuring economic development, and facing future economic, social, and environmental challenges. Thank you.
Thank you. Thank you, Dr. Shawky. That was terrific, and I'm glad it worked. It's really, really interesting to hear these perspectives from countries and to hear some of the commonalities, some of the challenges. Next up, it's Professor Jeanette Vega. Dr. Vega is the Chief Medical Innovation and Technology Officer at Red de Salud, UC-Christus. Dr. Vega.
So basically, I wanted to present to you the situation in Latin America and the Caribbean. This situation is around 4 days ago. We had around 500,000 cases and around 30,000 deaths. Next slide, please. So if you checked the lethality rates, you can see that there are a lot of differences in lethality rate. This is some selected countries, and my own country probably has a very low lethality rate compared with the rest of Latin America. Of course, I don't have here Brazil, but if you go to the next slide, you see what is going on in my region. This is the daily confirmed case, and you basically see that we are in Chile. We are third in the region, but unfortunately, right now we are the first ones in terms of cases per million of inhabitants. So we are the country that is most affected right now with the epidemics. Of course, we do have more testing than other countries, but still, if we look at the positivity rate of testing, we have today in the metropolitan region 40% positivity rate. And for the total of the country, 22% of positivity rate. Today we have 80,000 cases, and we are growing at a rate of 4,000 cases per day. So we are becoming a kind of a New York situation, and we have all our hospitals completely full. We are ventilating patients in the pavilions, in the pediatrics yards, in the emergency rooms, and we have increased our number of beds for critical care and ventilators more than double, and still we have 97% of occupancy rate. So we are also introducing, of course, oxygen at high rate and all the measures trying to get patients not to go to a ventilator. Next one. Having said that, the mortality rate, as you saw, is very close to what has been observed. Is around 1%, and the mortality rate, as shown in other countries, is mostly people in the older ages, around 85%, equally than what has been reported. However, though, we still have people that is hospitalized, mostly is middle-aged people, because older adults luckily have been staying at home. Next one, please. So I just wanted to show you a couple of slides showing the impacts in Latin America and the Caribbean. Next one. And you know, we are right now in the first phase, and we are having a lot of impact in terms of morbidity and mortality due to COVID-19. However, we are beginning to see impacts in terms of waiting lists for other origins and chronic health conditions increasing very quickly. We don't have still the number of deaths related to other conditions, and we also have some under registration of death. The other problem we are having is a very huge impact in terms of economic impact. Right now, today, the number of unemployment rate was announced, and it has achieved 15%. This hasn't been achieved since like probably 20 years ago. That was the last time we had that in one of, I think, the crisis of 2003, if I recall. Next one. So what we have been doing in most of the countries in Latin America is the same actions than anywhere else: massive testing, tracing and testing, supervised quarantine, population quarantines, and school closing, restriction of mass gathering, and restriction of entry of foreign travelers, border closing and controls. However, I do think that we made a huge mistake because we did not quarantine immediately and put in place the testing that we have today and tracing of contacts. And we are paying for that very, very heavily. Next one. And finally, I want to just to give you a short idea on what are the economic impacts that will happen in Latin America. Next one. So we know that the Latin American and the Caribbean economy will contract by 5.3% in 2020, and there are some countries like Argentina that would be extremely affected. In Chile, we will contract by near 4%. Next one. The unemployment rate will increase in average 3.4% from 8.1 to 11.5 as an average. And I told you that we increased from like 4% to almost 16% according to the latest numbers in these couple of months. And next one, please. And then the number of poor will increase by almost 30 million in the region. So we do have issues that are going to be quite complex. And the next one. And so if that is the case, I just wanted to share with you that we will be needing to expand the fiscal space in most of the countries. And that will mean, as it is within countries, a huge effort to facilitate access to financing on favorable terms, using lines of credits, reviewing conditionalities, and implement their forgiveness and relief efforts. In our case, one of the things that we have come to realize is that we need to put salaries for the people if we want them to be able to be at home. So probably in the next couple of days, a huge fiscal package will be announced using some of our fiscal reserves to make sure that we are able to provide salaries to the people that are being affected and make sure that they can be at home, because the latest survey showed that still 15% of people that are infected are going out because they need to go out in order to work. So I leave it like here, and then I'm open to comments or questions. Thank you.
That was terrific. That was really terrific, Jeanette. Thank you, everybody. It really was outstanding to get this sampling of comments from all over the world. Let me ask a question for everybody, if I may start. Can we go through with what's been the biggest challenge in country or region that you're speaking about to an effective response to COVID-19? Maybe we'll just work backwards. Maybe Jeanette, you can go first.
Yeah, well, I have a bit of a biased response, but I think that in our case, the biggest challenge has been the inflexibility of the government to listen to the scientifics and to listen to sort of people that have gone through this before. We told them, all of us told them that they needed to make sure that they implement a trace, test, treat and isolate policy very early, and that they needed to quarantine very strongly at the beginning while they were implementing that. In fact, they didn't listen. They did something, basically asked some modelers and went through something that they invented that it was called like strategic quarantines, which basically worked fine while the virus was in the counties with the highest socioeconomic conditions, but now it's completely, the system has been completely overwhelmed because now the virus has become very prevalent on the poorest communities.
So, so from your perspective, it was political refusal to listen to science. Sherine, how about from your perspective? Yeah. Sherine?
Okay. So actually there are two challenges. What's happening? Do you hear me now? Yeah, you can hear me. The first challenge in all the measures that the government has done was the compliance of the people. The people are not used for social distancing. The people are not used for staying at home for two things. First, the culture things, and by culture, we have religious effects, we have social events, and people love to come together. And also for gaining the money for living. People need to work, and we have lots of people in the informal sector that need to go daily to work, and they cannot stay home. The second challenge is a health system challenge. It's to find beds in hospitals for people, for hospitalizing people and for the quarantine hospitals. The number of beds that we have, the number of hospitals that we have are not enough for the number of people that really need hospitalization and quarantine. And I really don't know, the epidemic is growing now. What will we do in the coming days?
Thank you. Heidi, what are your thoughts about the biggest challenges that you faced in the UK? Heidi? Kalpana, maybe we'll go to you.
Oh, sorry, I'm here.
Okay.
Apologies. I think the biggest challenge right now, the challenges have changed over time from 2 months ago to now. They kind of evolve. I think right now, the biggest challenges are economic, people wanting to get back to work, people very worried, and schools. I think we're in this transition right now of, okay, it's waning, now what do we do? So I think it's this transition time. I would have answered that differently a few weeks ago.
That's interesting, actually. You make a very good point about the time frame. Kalpana.
I think the biggest challenge, in India is the sheer density of population. It is impossible, virtually impossible, to maintain any kind of social distancing with any amount of activities. So, the containment is our only strategy right now. But as you can see, going forward, if the rates of transmission were to sort of change from what it is right now, despite the lockdown has been quite successful, I think, for at least 60 to 70% of the population to be able to avoid places where the social distancing norms would be violated. But going forward, with any amount of resumption of economic activity and any amount of lockdown lifting, the social distancing norms are going to be impossible to meet for most people, even within their own homes and even within their own communities. It's not for pleasure; it's just the sheer
number.
The process of living is hard enough that you can't distance yourself.
Yeah, there is a question from John about the challenges of social distancing with informal urban settlements, which I think you've answered. Let me ask Kalpana a follow-up question, which also comes from John, which is, how are you thinking, and what's the national conversation like about the right balance between physical distancing and economic health in India, and the balance of the sort of the cure and the disease? And then I'm going to ask the other panelists as well on that.
I think the good news is that they don't have a one-size-fits-all approach right now throughout the country, as big as the country that it is and as populous a country that it is. A few cities and a few districts, only about 62 districts throughout the country out of the more than 500 are actually accounting for pretty much all the cases, despite testing are now available in most of the districts. So there will have to be some shift in the economic activity to those zones where we have a bigger advantage in terms of the transmission rates or in terms of the current incident rates of the infection. So that may be one strategy. So even within a state, for example, you have several districts that are actually opened up for economic activity. So it may be necessary temporarily to either facilitate remote work or to facilitate, some physical shifting of the economic activity in such a way that the hotspots are not, further taxed in a way that the hotspots explode and end up, inoculating the non-hotspots.
Jeanette, I'm curious your thoughts on that.
I do think that there is this is a question that almost everybody is asking, but the thing is the following. I mean, in countries like mine, at least, what creates capital is basically making sure that we have production. But in order to have production, given the type of production that we have, we need healthy workers. So there is no way we can recover our economy if we don't recover our people in terms of health first. So in fact, it's a pre-requirement to get the economy back, to make sure that we can get our workers back to work. And in order to do that, we need to protect them now, make sure that we do quarantine extensively the country. And then, because right now, everything is COVID. So there's no point in basically doing anything else, even testing. So that's the current strategy.
No, I appreciate that. And I also think it's a false dichotomy. I agree with you completely. We have time for just one more question. I'm going to go around all the panelists quickly. And the question is a forward-looking positive one. Hope. I would like to hear from each of you one thing that has happened in the time of COVID that has given us hope. I'm going to go through very quickly because we're running out of time. Kalpana?
I think in efficiencies in work processes, I think it has sort of really allowed us to appreciate that there are just so many ways that technology can be used, even in resource poor settings, to increase efficiencies. And if they are applied, I think societies and communities will greatly benefit, as would the economy.
Thank you. Heidi?
I think one of the biggest things that I found moving and positive was the level of volunteerism. Huge number of people have come forward to, either help people living alone, getting food, getting what they need, getting medicines. There's been a real, to me, the level of volunteerism has been tremendous. And in general, cooperation. We're going through a bit of a challenge now with the transition. But in the last couple of months, that's been very moving.
Thank you. Volunteerism Corporation, Sherine.
Okay, I think the COVID-19 is an opportunity to appreciate the role of the health system and the healthcare workers and the importance of having healthy people for a more developed and better future. It was also an opportunity for a country like Egypt to strengthen the infrastructure and to make use of better technologies and more technologies in everything. I've seen in the past days solidarity, work together, people fearing that their friends, colleagues get sick or get affected by the COVID-19. So it's a way of much more social cohesion that maybe we forgot in the past days.
Thank you. Jeanette, you get the last word.
Well, I think that there are two things. One is the promise, the hope of a realization of digital health. And the second one is the hope that governments will realize what happened when we stop the engines of the world in terms of climate change.
Well, those are really interesting answers. Please join me in thanking Drs. Balakrishnan, Shawky, Larson, and Vega for a really interesting perspective from all over the world. I thought it was fitting to end on hope. I do think this is an extraordinarily difficult time all over the world, but I also think that it gives hope. There's a lot that can give us hope. And I think hearing from what's happening around the world it gives us lessons that we can look forward to. Thank you, all of you. Thank you for everything you're doing. Thank you for joining us on this conversation. And thank you to the audience who participated in all this. Everybody have a good afternoon, evening, and day.
Thank you.
Bye.
Bye.